and I'm going to say, can I have a take a look at your name badge, look at their name badge, and say, can you please confirm your name for me? Okay? I'm not coming in saying, hi, their name, hi, Mrs. So-and-so, because I want them to confirm. So if I go in and tell them that, then if they're confused, they're going to go ahead and say that. So if they tell me their correct name, then I know the correct name. If they do not give me the full name, or they don't know, then I might say, is your name start with this? Because now I'm trying to check orientation, okay? I don't ask them, can you tell me the date? Can you tell me the time? Because I don't even know it, okay? Seriously, I don't even know what it is today, Wednesday?
Third.
Yeah, Wednesday, third?
Wednesday.
So I don't even know. That's why
Well, I guess tomorrow's the
my
fourth,
phone's like,
that's
what's the
why.
date today? I don't even know. So I don't know, ask the patient. And half the time we're writing it on the board inside the room anyway. So how are we really checking their orientation? So I go by asking them those type of questions. If I know that their family member just left, say, oh, who just left? Can you tell me who was here visiting you? What's on TV? You know, kind of get, they're answering questions, they're currently giving you that responses, then their orientation is times 3. Okay? If they do not answer those questions, then I'm going to go into more of those detailed questions. Can you tell, do you know where you're at? Do you know why you're here? What's going on? You know, what's happening with that? All right. So once I get that established, I'm going to go ahead and say, okay, well, I'm going to go ahead and take your vital signs. For you, I don't need you to take the vital signs. I want you to tell me what they are. So you'll take their vital signs. Then you tell me blood pressure, pulse, respirations, temperature, okay, pulse ox, and can you tell me if you're any in pain? Okay, if you're any, and ask what kind of pain is. Okay, on a scale from 0 to 10, 0 being the least amount of pain, 10 being the worst amount of pain, what is your pain level at? Okay. Then, this is the main thing, the patient says they have a pain level of 4. Okay. With a pain level of 4, what is tolerable for you? Can you tolerate a 4? Or is it a little bit higher for you? Because every single one of our pain levels is different. Okay? And it's a well-known fact that women have a higher threshold than men. Okay? So,
Pregnancy.
you gotta always double check that.
Ruined it.
Okay? Because her threshold might be 8. She's at a 4. Are we okay? Plus, I want to check for pain before I start moving the patient around and doing stuff. Because if the patient's in pain, nothing else is going to happen. Okay? So check for a little pain. Level 4, we're okay. We don't have to give any medication. Okay? So I do my vital signs, and I know her pain level. Okay? We're going to start off with our head and move our way down. So, go with the head. I already washed my hands and stuff. Wash my head. So I know with them, they're teaching you to kind of go in here and touch their head and stuff like that. Really? So I asked the patient, do you have any, are you feeling any pressure or any pain? Do you have any headaches, any sinus related problems? Can you point to that area that it's at? I ask the patient often to engage in my physical assessment. If the patient can do this and point to their head, the patient can follow directions. Right? Okay. So I'll go ahead and apply pressure. How many people have had facials before? You guys all need to go out and get some facials.
I know.
Okay.
No one
So when they give you a facial, you know how they push those certain points? Those are pressure points. Those are usually where your sinuses are at. So if a patient says, oh, I'm feeling pressure right here, we know it's probably sinus related. Okay? As opposed to, oh, my head is hurting right here, or it's heading back here. That's not usually sinus related. Okay? So that's why we got a hangover.
Yes.
Where's our headache usually?
All over.
All over.
Especially in the back,
okay?
though.
Because we don't have enough fluid, right? We're dehydrated. So you have to make sure that what is that headache? Where is it resolved? Where is it at? So I can help the patient. Do I need to give them something for it? Or do I need to push fluids? Or do I need to give something to help drain those sinuses? That's what I need to do. Because I got to call the doctor and, what's that R? Recommend something for our sinuses. Okay. Okay. So see how it all comes back to that S bar? All right. If the patient was in a trauma, went in a car accident, fell, then yes, I'm going to go ahead and start filling the head and feeling for anything else, okay? As I'm doing that, I'm applying for any pressure. Do you feel any pressure there? And I'm going here, I'm feeling behind the ears, and I'm coming up along underneath the neck, okay? At this point, I'm just feeling for any kind of swelling, okay? You're not doing a complete higher level nursing assessment. You're just going to feel like for some swelling. So So I'm pulling up here. I can actually, your JVD, if you want to, you can actually start palpating to see if you feel any distension, but do not go down and press down, okay? You just want to go and feel, just slightly palpate. She kind of feels like she has JVD because of the way this neck is, but she really doesn't, okay? All right, so as I'm doing that, I'm looking at the ears, I'm looking for symmetry, I'm looking at the eyes, I'm looking for any drooping, to see anything's going on, so I'm looking facial symmetry as well. Looking at the nose and making sure, and looking at the mouth. So I'm just doing a visual inspection with that. Once I get to that point, pen light. Pen light, anybody?
We're so unprepared.
Flashlight. I have one. And we use the camera.
So you check the neck only when there's head trauma, or
Yes, I
you?
do.
Do you want us to check?
There's an app for that?
Okay,
I've had them.
I got one now. So when they're telling you to kind of do this type of thing, that's when you're checking for feeling his trauma. But otherwise, I'm still kind of giving doing some pressures to feel they feel any pressure and going along with it. I'm still feeling. Touch is one of the best things that we can do for a patient. Okay, don't be afraid to not touch a patient. Okay, so I'm going to now look at the eyes. So what I want the patient to do, and I tell the patient to do this, is I want them to take their hand, and I say, take your hand and do this for me. I want them to go and do this for me. Okay? And the reason I do that is for two reasons. One, I'll be able to follow directions, and two, I want them to give me that barrier so when I put the light in their eyes, I'm able to see what's going on. Okay? Because normally you should be able to do that. Okay? Because you're going to do the light 4 times. Okay? So the patient's able to put their hand up like this. I'm going to come shine the light from the side. I'm going to pull it up. Look at that one. Go to this side. Look at that one. Then I'm going to come back over here, and as I shine it into this light, I'm looking at this eye.
To see how it constricts
Okay?
also.
Yes, I'm trying to see is the other one following suit. Okay? So one, I'm looking to see if this one's working. Then the second time, I'm looking to see if the other one's accommodating the same thing. Okay? The other reason why I also have the patient do this is often when you tell someone to do that, they usually do it with their dominant hand. So I usually tell the patient, oh, are you right side dominant? Are you left side dominant? And they say, how'd you know that? Psychic.
That was smart.
But it usually kind of gives you an idea to know what dominant side to put the stuff on. Okay? So we check the eyes, I'm looking to make sure. Okay, now I have them to put their head down, and then I said, okay, follow my pen, okay, and come down, come up, and I tell them I don't want you to move your head, just follow with your eyes. Okay? Perla. Perla. Okay, Perla. So I've already looked for symmetry, looking for any kind of drainage or anything like that, see if there's anything, mucus or anything like that. Check the nares. I want to see if there's anything wrong with that. Now that's when I have to go do, if I do an NG tube, I'm going to check for patency, but I don't really need to do that right now. I just need to look. If they have oxygen, then I want to make sure. Look for the oxygen, look for any redness area, see if there's any breakdown, and follow that behind the ears, okay? And then follow the oxygen to the source. For those of you who weren't there today, I always go from insertion to the origin, okay? Insertion, always go from the patient first to the origin, making sure that the patient's always first, safe. Okay, so check here, making sure the oxygen is at 2 liters where it's supposed to be, and we're okay with that. My saturation is good, I already checked that. Okay, I'm going to inspect to see if there's anything else. I'm going to go to the mouth and see if the mouth, I'm going to have them open their mouth. So you inspect the mouth to see if everything's okay. Because you want to make sure you're looking for thrush. Especially a patient who's been in the hospital for a while, you're going to see that tongue is all white coated. So either they're not getting proper oral care or they're getting thrush, which is a response to some medication. Okay, so you really want to check that. So you have them do that. Stick up their tongue. Okay. And you inspect it. You don't have to stick anything down their mouth to gag them. There's no reason to do that. If the patient is MPO, I'm going to go ahead and say, here, why don't you go ahead and sip a little bit and take a sip of water. Checking for gag reflex. If they can swallow, they're okay, right? All right, so if they're MPO, I'm not gonna do any of that. All right, so I'm checking, I've already checked for JVD. I'm gonna ask that I can move down their gown a little bit, okay? And normally what I do is I'll go ahead and put my hands right here on top of their shoulders and say, go ahead and shrug your shoulders for me, okay? And then I have them go ahead and go back down. So you can shrug your shoulders, okay? Then I'm gonna have them turn their head from this side to this side, come down and back, all right? Have them smile, have them frown, okay? I've just checked my cranial nerves. We're done. Everything's intact, okay? So I'm good there. Now, from this point, I'm gonna go into what system?
Respiratory.
Yeah, it's way down here. Okay, so I'm going to go into cardiovascular and respiratory. So normally for me, what I won't do, I will not do this. I go straight to the GI. For those of you who said that, I go straight to GI because I don't want to get the bowels moving. But for your sake, we're going to check here first. So I'm going to come here first. So I want to check for the lung sounds and I'm going to check for my heart sounds. So I'm going to grab my stethoscope and tell the patient just to breathe normally, and they can refrain from talking, and I'm just going to listen to the lung sounds. Okay? So you guys are learning 8.
8 front, 2 1 side, stem to the back.
Okay. So I want you to,
Well, for us, she said 6 in the front and then 8 in the back.
God, why do we
Okay,
need
Mr.
different
Cordova, what is
stuff?
it gonna be?
okay.
Just tell us what we
So
need.
look, 1, 2, okay, 3, 4, 5, and you're always going from side to side, okay? 7, and then down here. Why on this side? Wait. Why are we coming down on this side?
You asking me?
Yes.
Hello.
Go ahead, everybody.
He's the one that said it
I
last
know.
time. That's what he was asking.
No, he was the one that
Yeah, he was the
didn't.
one that said it last
I got it mixed up, remember?
You gotta mix
Yeah.
that. Where's the 3 lobes?
3 on the right, 2 on the left.
Okay, that's why on that side we really want to go down. Okay, on this side we don't have to go down as far because of the lobe. All right, so check our lung sounds. For our heart, and you always want to make sure that when you're auscultating lung sounds, you're auscultating on skin. Okay, so I'm going to go like this, come down, and then I'm going to pull the patient's gown up. Okay, and then finish listening to my lung sounds. Okay? I don't need to uncover her just to listen to the lung sound. While I'm here, I'm going to go ahead and listen to the apical heart. So, back of your hand, lift it up, and listen. Of course, most of your patients are old females, so they're already down there. So just right there. Okay? So if you have an older female, don't worry about it. Okay.
Wait,
Some of your males, some of your
Is that a
males.
female over there in the middle?
That's kind of a hermaphrodite.
The shit. I was wondering about that one. You'll see it.
So, just make sure that you guys do not have to go and do this. Okay? The only time that you really need to inspect any female's breast is,
You're doing a breast exam?
huh?
Like breast.
There's
They've had a...
Postpartum. OB, okay? Unless they're coming in there for some other thing,
stuff.
okay? OB. So, otherwise you don't have to go and say, leave those open. All right? So we're having to do that. Listen to the lung sounds. Listen to my apical heart for, okay, 1 minute. And then also when I'm listening to the apical heart, I'll go ahead and listen to the apical heart and I come down here to feel the radial pulse. I'm listening and I'm feeling to making sure, are they in sync? They should be pretty close to being in sync. Okay? So I want to make sure if I'm identifying the same sound and then I'm listening for any abnormalities in the heart rate or rhythm. Okay? All right. While I'm here, I'm also looking at the skin. For an elderly person, this is where I'm going to check for skin trigger. So I'm going to pinch sternum to see if there's any tenting. Okay? Now, you have to be careful because if it's an elderly person, you're probably going to see some tenting. So don't, make sure that that's because of skin elasticity, not because of dehydrate. Okay? All right, so I'm going to get to the lung sounds in the back in a minute. I'm going to now have the patient do me a favor. Want them to raise their hands. Okay, raise your hands up above the bed. Turn their hands, go back up, wiggle your fingers. Okay, so I'm looking for a range of motion. Are they able to move their hands? Are they flexible in extension? Okay, go ahead and palpate my pulses, radial pulses, bilateral. Okay, and then I'm going to go ahead and have them squeeze my fingers. Okay, some people do this or crossover or whatever. It doesn't matter, just come looking for strength. Okay, go ahead and push up. Okay, go ahead and push down, looking for their strength. Okay, so I did mobility. The patient has an IV catheter. I'm going to look at the IV site to see how the IV site is. Is it intact? Is it a saline lock? The saline lock, how's the site? Is there any redness, swelling, infiltration? Okay. Notice the size of the IV site. Okay. Look at the date and see when it was last placed. Know your protocols for the hospital. If it's hooked up to fluids, then again, I look at the site, look up here, follow along, making sure the tubing is okay, following along to here. Is it running at the rate that it's supposed to be? And is this patient, and this is the right medication? I got that all in report, so I should know that. Okay? If it's not, then I need to report that to the nurse. All right, I'm going to come down here. I want to check my cap refill. Should be,
Less than 3.
okay, check the cap refill on both fingers. I can check for any kind of bumps or bruises. Normally what I do is I go from one side to the other side, so I don't have to keep on going over the patient, and I don't want to keep on walking from back and forth. So I usually start on one side and then work my way around. Either way, it doesn't matter. So you need to do that, and you can have them come here, looking for any sites, looking for any kind of bruising and things like that. Okay? All right. So now I'm going to come to my GI. I'm going to observe my site. Okay. What am I looking for? Lumps, bumps, or bruises. Okay. Any distension? Do I see anything from any injection sites that they've had, from Lovenox to insulin? Was there any bruising or any possible scar tissue that you can see? Any history of surgeries or anything that that you can see, any scars, and then ask them about that. Okay. So I've done my observation. I'm going to auscultate, starting at the right lower quadrant. Okay. How long do I have to listen for?
Till you hear sounds.
Okay. If you don't hear any sounds?
5 minutes.
5 minutes. Okay. Why 5 minutes?
Maybe it's just a slow digestive system.
Okay.
They're older.
Also, I need to be aware of what kind of patient this is. Is this a post-op patient? Am I going to hear any bowel sounds? Okay. The post-op patient, no, I'm not going to hear any bowel sounds because they don't have anything. I've been MPO. Okay. If they're MPO post-surgery because they had GI surgery, do you think I'm going to hear any bowel sounds for the next couple of days? No. So don't be like, oh my God, I don't hear any bowel sounds. Well, you don't hear any bowel sounds because there's not supposed to be any bowel sounds. Okay, so know what your abnormal normals are going to be. But for you and I, if we're going here and we're listening, we should hear bowel sounds. Okay? For a normal person, if I don't hear bowel sounds, what is that telling you?
Check this one.
Bowel obstruction.
Possible obstruction. Okay? So that's what we're listening for up to 5 minutes to see, do we really hear nothing? Okay? Go to your next right upper quadrant, left upper quadrant, left lower quadrant. Okay? Then I'm going to go ahead and palpate. Okay? So I'm just going to go, and I'm not going, okay? All I'm doing is kind of doing this slow movement, and ask the patient, do you feel any pain or discomfort? Okay? And you're just trying to feel. Do you feel anything? And we're feeling along that colon, right? That's what we're palpating, is the colon area. All right. If the patient says that they feel something or they feel it hurts or distended, then don't keep on going on there. Just go ahead and say, okay, can you tell me what the general areas or point to the area? Because I can see that there's some distension here. Okay, so I know that this is possible location. Okay, and then percuss. Okay, we're hitting our own finger. You should hear a tympanic sound. If there's obstruction, you're going to hear a dull sound like. Okay. Zip it. Okay. All right. Patient, when was the last time you used the restroom?
Yesterday.
Yesterday. Okay, yesterday. And how was that bowel movement?
Formed and smooth.
Was it formed? Okay. Did you have any difficulty?
No.
Okay. How often do you go? Do you go every 2 days or every day?
Usually once a day.
Was it once a day? So yesterday was the last day?
Yesterday.
Okay. And you haven't gone today?
No, not yet.
What time of day do you normally go?
6 a.m.
6 a.m.? Okay, it's already